titled Addressing the Mental Health Needs of Adolescents aged 10 to 14 years in the Western Cape province of South Africa. My name is Mirriam Mkhize. I have a master's degree in social work, and I've worked as a clinical social worker with children and adolescents, offering psychosocial support and counseling, as well as a research project focusing on adolescent health and well-being. I've divided my presentation into four main parts. Firstly, focusing on the research objectives, the background, the methodology, ethical considerations, and finally, the acknowledgements. I have four research objectives for this PhD, and they have all been formulated based on the gap in the available literature. The first research objective seeks to determine the prevalence, risk, and protective factors associated with common mental disorders among adolescents aged 10 to 14 years. The second seeks to validate and determine the psychometric properties of the Generalized Anxiety Disorder Screen 7, Center for Epidemiological Studies Depression Scale for Children, the Patient Health Questionnaire for Adolescents, which are all mental health screening tools to be used among adolescents aged 10 to 14 years. The third is to co-adapt the Early Adolescent Skills for Emotions Ease intervention for use among South African adolescents aged 10 to 14 years experiencing symptoms of anxiety or depression. And finally, to determine the acceptability and feasibility of the adapted EASE program for adolescents aged 10 to 14 years experiencing symptoms of anxiety or depression. The first objective for the study aims to fill the gap in the available literature on the prevalence and associated risk and protective factors associated with common mental disorders among adolescents. Currently, there's limited and unequal distribution of prevalence data in low-middle income countries, including Africa. In South Africa, a few studies have explored the prevalence of common mental disorders among this population and indicate common mental disorders range between 10% to over 20% in South Africa. However, these studies are disproportionately focused on older adolescents who are usually 15 years and older, who are in school settings and high-risk adolescent populations, mainly those living with HIV and AIDS. The focus for this particular study will be on South African adolescents aged 10 to 14 years. Now, moving on to risk and protective factors, which impact on adolescent mental health. The social ecological model framework, as you see on the screen, will be used. So as you can see on the screen, the risk and protective factors in this model can be categorized according to individual factors, household and family factors, school-related factors, and community factors. I won't go into detail, but you can see that at various levels and based on the available literature, exposure to traumatic experiences, poor parenting, social and emotional regulation skills, exposure to negative peer relationships, namely bullying, and the effects of COVID-19 pandemic have been associated with this particular population of young adolescents developing common mental disorders. The second objective aims to validate and determine the psychometric properties of several screening tools. In low-middle income countries, common mental disorder screening tools are most popular to detect mental disorders, given that they're easy to use, they're cost-effective, and can be administered by non-specialists. However, only 11% of these tools have targeted children and adolescents. Thus, little is known about the validity and the psychometric properties of depression and anxiety screening tools in low-middle income countries. And very few studies have validated screening tools in Africa and South Africa. Regarding the GAD-7, the PHQA, and the CESD tools, although they've all been used in South Africa, none of them have focused on adolescents who are between the ages of 10 to 14 years. Most mental health screening tools for this demographic mainly rely on parent or teacher measures, thus fostering a major gap in self-reported measures for those who are 10 and 14 years. Thus, this study seeks to address this gap by validating and determining the psychometric properties of these measures, and also to see how these measures perform among adolescents aged 10 to 14 years. This objective moves to adapting and testing the feasibility of a prevention program targeted at adolescents aged 10 to 14 years. Given the onset of mental disorders occurs at 14 years and even earlier, interventions during this period provide a window of opportunity for mental health promotion and prevention. And in order to reduce the burden of mental disorders among adolescents, an emphasis has been placed on indicated prevention interventions, which are aimed at high-risk individuals with an already observable mental health symptom. And although prevention interventions for adolescents have been widely tested and mainly developed in high-income countries, scholars have highlighted key ingredients for effective prevention interventions, and these include addressing a range of emotional and behavioral problems, and the compromise of a range of skills, including cognitive behavioral therapy skills, as well as problem-solving skills, and they've been used in multiple settings by non-specialists. The particular intervention that will be adapted in this study is a World Health Organization EASE intervention. The EASE indicated prevention was developed for young adolescents between the ages of 10 to 14 years with symptoms of anxiety and depression and who live in communities which are affected by adversity. The EASE intervention has 7 adolescent sessions exploring emotional regulation, behavioral activation, as well as problem solving, and 3 caregiver sessions focusing on psychoeducation, including positive parenting, with each session having a duration of 90 minutes. This intervention is currently undergoing clinical trial testing in 4 countries in low middle income countries. And although the EASE intervention has been specifically developed for use in low middle income countries, it is important to explore its acceptability and feasibility within our South African context. And interventions that have included both adolescents and caregivers may be particularly important in our context, given the impact of parenting practices have on adolescent mental health outcomes. Thus, this study seeks to co-adapt the EASE intervention and test the acceptability and feasibility of the intervention among adolescents and their caregivers in community settings. Moving on to the methods, which will take place in 3 phases. Phase 1 will address the prevalent associated factor and validation of the screening tools. Phase 2 will co-adapt the EASE intervention, and Phase 3 will test the feasibility and the acceptability of the adapted EASE intervention. Given that all the procedures for the study will take place face-to-face, all COVID-19 pandemics and regulations as stipulated by the University of Cape Town's Research Office will be followed. For phase one of the study will take place in school settings within the Western Cape Province, as you can see depicted on the screen. This will be in collaboration with Students for Better Future organization. SBF will provide scholarships and fellowships as well as psychosocial support to learners and students in the province, as well as community keepers who partners with approximately 28 schools in the province to provide psychosocial support and counseling to children and adolescents. Both of these organizations support adolescents who are exposed to a high level of adversity, including violence, crime, and poverty. The sampling size for the study will be calculated using Panduzzi et al. 1996 formula as shown on the screen, with the inclusion of 12 independent variables and a predicted 20% of adolescents screening positive for anxiety and depression, providing an estimated sample of 600 adolescents. Learners will be sampled from approximately 6 schools in 6 primary schools in collaboration with the Department of Education, CK, as well as SBF, who meet the following inclusion criteria. Firstly, adolescents must be enrolled in selected schools within the Western Cape Province districts. And secondly, they must be between the ages of 10 to 14 years. And thirdly, parental consent and adolescent assent must be provided. The study will utilize a descriptive cross-sectional research design in order to determine the prevalence of risk factors, of the prevalence, associated factors, and risk and protective factors associated with common mental disorders in school settings within the Western Cape Province. Now, moving on to the measures. For this particular study, we'll potentially include 3 measures. Firstly, the social demographic and social demographic questions and measures, mental health measures, including the mini-kids depression and anxiety modules, as well as depression and anxiety measures which will be validated. Lastly, based on the literature review, particularly the mental health socio-ecological model, the following potential risk and protective factors will be included in our context. Moving on to data collection. First, a pre-testing of the survey will be conducted with SPF-affiliated students with the focus of cognitive testing, the items of the GAD-7, the PHQA, and the CESDC, and this is in order to explore participants' understanding and accuracy of these measures. The cognitive testing will be guided by Collins' 2003 four-step question and answer process. After that, approximately 6 schools will be identified and approached with the approval from the respective principals. A team of researchers will go into the classroom with the students ranging in ages from 10 to 14 years, where a description of the study and the consent process will be provided. Learners will present their guidance with the consent forms, and a telephonic follow-up will be provided for those learners who do not return the consent forms, and the researchers will administer verbal consent with those particular guardians. Following the informed consent and assent procedures, on the agreed upon date and time, the research team will approach the adolescents who meet the inclusion criteria. The study purpose and procedure will be described again. And with regards to the data collection instruments for this phase, we will be using electronic surveys, which will be administered via tablets. This is the most effective and self-administered method. It's also age appropriate and has been used widely in previous studies among this demographic. The tablets will be distributed to each learner, where a short tutorial on how to complete the survey will be conducted. Prior to the initiation of the survey, 10 participants will be randomly selected for the MiniKid diagnostic interview, where 5 trained clinical research assistants will interview 5 participants prior to the survey and 5 after completion of the survey. During the interview, the depression and anxiety modules of the MiniKid will be administered, and this is in order to validate the GAD-7, the PHQA, the CES, and the CESDC tool. The survey will take approximately 45 minutes to be completed. And lastly, in order to determine the test-retest reliability of the 3 measures, after 2 weeks of the initial survey, 2 schools will be identified, and the adolescents will be asked to only complete the depression and the anxiety measures again. Moving on to data analysis. The statistical package for social sciences, SPSS version 28, will be used to analyze and clean the data. This tool has this software has been chosen because it's most easy to use, and it generalizes a range of descriptive and inferential analysis which are relevant for this particular study. Frequency distributions and descriptive statistics will be conducted on will be calculated for the categorical and continuous variables that are relevant for the study. The prevalence rates will be conducted based on the various cutoff scores of the GAD-7, the PHQA, and the CESDC, respectively, and the 95% confidence intervals will be calculated for the common mean concordance. Unadjusted and adjusted associations between the social demographic variables, associated risk and protective factors, and depression and anxiety will be analyzed, and the results of these regression models will be reported as odds ratio and 95% confidence intervals. The receiver operating characteristic analysis will be performed in order to evaluate the screening properties of the 3 measures using the MiniKid as the gold standard. The ROC curve will be tabulated in SPSS, indicating the sensitivities and the specificities at various cutoff points. Pictorial validity of these screening tools will be measured by performing a principal component analysis with variance rotation. The comic alpha coefficient will be used in order to evaluate the reliability of the 3 measures, and test-retest correlation will be tested to determine the stability of the 3 measures, the stability of the scores on the 3 measures. Moving on to data collection. Phase 2. For phase 2, data collection will be primarily among SPF-supported students in 2 main informal settlements, Ms. Amoyetu and Handberg in Houtbay, as you can see depicted on the screen. And for this particular phase, 24 adolescents and caregiver dyads who meet the inclusion criteria will be recruited. The inclusion criteria that the caregivers and the adolescents must meet include that the adolescents must be between the ages of 10 to 14 years. They must screen at risk for depression using the PHQA and meet the cutoff score of 15, and anxiety using GAD-7 and meet the cutoff score of 10. The written informed consent and assent from both the caregivers and the adolescents will be sought. And lastly, they must both be willing to attend all the EASE program sessions. And those who do not meet the inclusion criteria will be excluded, and those who screen high at risk for psychological distress will be referred and followed up to ensure that they receive mental health support. The focus for this particular phase is to co-adapt the EASE program, and this will be guided by Banzano et al. 2017's human-centered design approach. The human-centered design approach is an iterative process of designing prototypes with users, and in this case, it will be co-creating ideas on the specific content, material, and delivery platforms with the dyads for the EASE intervention, since it's already been adapted for use in low middle-income countries. The co-adaptation process will be guided by the ecological validity model, comprising of 8 domains as shown in the chart, including the language, the context, or methods, and so forth, in order to guide the changes of the intervention components, the content, and the materials through the following steps. Firstly, the first cohort will be recruited and the whole EASE program will be delivered. After each session, a focus group will be conducted to get participants' input on the experiences and suggestions with regards to accessibility and visibility of the intervention components and materials. Secondly, the revisions will be modified into version 2 of the EASE program, and this will be based on the EVM domains. Thereafter, version 2 of the program will undergo a similar co-adaptation process, and we will then get further feedback and suggestions on the intervention from the adolescents and the caregivers. We anticipate approximately 3 cohorts for this phase until no new modifications are suggested. A stakeholder advisory group comprising of mental health experts, researchers, and other representatives from mental health organizations will be consulted throughout this adaptation process in order for them to provide feedback on the modifications and final approval of the co-adapted EASE intervention prior to testing in phase 3. And these consultations will mainly be online. For phase 3, a non-randomized feasibility study supplemented with qualitative interviews and focus group discussions will be used in order to determine the acceptability and feasibility of the adapted South African EASE program. A mixed method design is most suitable in exploring the feasibility and feasibility of the adapted EASE intervention, and it's also useful to inform future randomized control trials. Phase 3 will be conducted in community settings in the Western Cape Province in partnership with the already mentioned organizations, and this process will be guided by the reporting guidance for non-randomized pilot feasibility studies and template for intervention and replication guidelines. 80 adolescents and caregivers will be recruited who meet the inclusion criteria. The similar recruitment and content assessment process will be followed as I've already described for phase 2. However, for phase 3, given the sample size and considering barriers to recruiting dyads as highlighted in previous studies, an exception will be made for caregivers who are unable to participate but give permissions for the adolescents to participate in the EASE program. Moving on to data collection. The concept diagram on the screen highlights the study procedure for phase 3. Firstly, verbal consent will be sought from adolescents in order for them to be screened for eligibility for inclusion in the study. All eligible participants who meet the inclusion criteria will have the study described to them, followed by the informed consent and assessment processes, as I've already described in phase 2, through community organizations, and this includes the recruitment of caregivers. Exclusion criteria for phase 2 will also be applied, and the referral pathways, as I've already mentioned, will be followed where necessary. 10 adolescents and caregivers will be invited into the baseline assessment, and session 1 of the Adapted South African EASE program will be initiated through face-to-face sessions. The EASE program, as shown on the screen, will be conducted 1 week apart. After each session, refreshments and vouchers for caregivers will be provided, and the sessions will take place within a period of 12 weeks. Follow-up baseline assessment will be re-administered after 1 week and 3 months post-intervention, giving a 30-day window period. A random sample of 20 adolescents and caregivers will be invited for semi-structured interviews in order to explore the acceptability, feasibility, and suggestions for improvement on the adapted EASE program. This concludes the study procedures. Now moving on to training and supervision. Facilitators will be recruited who have an honors degree in either social work or psychology and are registered with the respective professional bodies. They will receive a 5-day training from a World Health Organization consultant on the delivery of the EASE program. I, as the PhD candidate, will also receive training on supervision methods for ease monitoring fidelity, and I will also be supervised by expert clinicians. Moving on to facilitator competencies. Following each session, the facilitators will be provided with structured feedback on the program delivery and facilitation skills by me, the PhD candidate, and I will also observe each of the sessions in order to provide feedback. And this will be done through the intervention validity checklist and the group act in order to evaluate the facilitators' competencies and skills. The primary outcomes for this phase will be to firstly explore the feasibility and acceptability outcomes. The feasibility outcomes will include exploring participant perspective with regards to the recruitment process, appropriateness of the data collection procedures, outcome measures, the retention of the adolescents and the caregivers in the program, and the ease facilitator competency, as well as the presence of adverse events and acceptability of the intervention for adolescents and their caregivers. Secondly, acceptability outcomes related to study procedures, which include screening, consent, process, and the length or duration of the intervention, tracking and follow-up assessments will be explored. Finally, to assess overall satisfaction and to assess overall satisfaction with the intervention and how it was delivered, the child evaluation inventory measure will be used. And secondary outcomes for the study may be the potential measures identified for future randomized control trials, which include adolescent and caregiver measures as highlighted on the screen. Now moving on to data analysis. SPSS will be used in order to analyze the feasibility outcomes using descriptive statistics, and these will be presented over time for the feasibility outcomes. Means and confidence intervals for the clinical outcomes, although this is not a primary outcome for this particular study, it will be calculated using dependent t-tests in order to examine the clinical changes over time. Qualitative data analysis will be transcribed and translated from the semi-structured interviews and focus groups exploring participants' perspective of the feasibility and acceptability of the intervention, barriers and possible facilitators of participation in the EASE program using in vivo qualitative software. Thematic analysis guided by Brown and Clark's 6-step of conducting thematic analysis will be used in order to analyze this data, and this will be in line with the consolidated criteria for reporting qualitative studies. This concludes the research methods. Now moving on to ethical considerations. There are 5 main ethical considerations for the study. Firstly, focusing on the importance of human participation, protection through the study undergoing a full ethical approval process at the University of Cape Town Research Ethics Committee, the Western Cape Department of Education and Health with regards to approval regarding conducting research with minors, in order to ensure that the study will not predispose participants to any harm. Secondly, risks and benefits. Given that the study will be addressing mental health related topics, in order to mitigate any potential psychological harm, proper risk assessment and referral pathways will be provided, as I've already explained. And participants may potentially benefit from the opportunity to receive the EASE intervention, which may potentially increase their social and emotional skills, as well as potentially reduce psychological distress. Thirdly, the verbal and written and verbal informed consent and assent process will be undertaken at various points of the study, as I've already mentioned, and these will be provided the participants' language of choice, either English, Afrikaans, or Xhosa, and permission to audio record the qualitative components will also be included in the informed consent forms. Autonomy and confidentiality will be ensured by the researcher omitting any identifying particulars such as participant's name, for example, and instead using participants' identification codes, and this will also be outlined in the research information sheet. And lastly, participants will be reimbursed for their time participation, and I've already stated that they will receive light refreshment at the end of the session. Caregivers will also receive grocery vouchers, and adolescents may receive the mental gift at the end of each of the sessions. The references cited for the purpose of this presentation will be available upon request. And to conclude, I would like to thank the Sue Struengmann Initiative for funding this PhD, the World Health Organization for permission to use the EASE intervention, Community Keepers Organization, and Student for Better Future for their potential collaboration. Thank you for listening, and this concludes my presentation.
Thank you very much, Mirriam, for an excellent presentation, and well done for pretty much sticking to time. That was great. Okay, so I'm now going to introduce our reviewers. We've got two reviewers. We're delighted to have Dr. Usman Hamdani from Pakistan and Prof. Kathy Matthews from South Africa. Prof. Matthews can't be with us today, as Catherine said, so I'll be reading out your comments. But I first just want to introduce Dr. Usman Hamdani, who's the Director of the Global Institute of Human Development and also Director of the Human Development Research Foundation in Pakistan. And he's also a clinical lecturer affiliated with the University of Liverpool in the UK. So can I hand over to you, Dr. Hamdani?
Thank you so much, Catherine, and thank you so much, Mirriam. It was an excellent presentation. And I think the area that you're touching upon, the adolescent mental health, I think that's a very important area. And the questions that you're raising are really important questions. So first of all, I would like to congratulate you and your supervisory team on putting together this very thorough and very well prepared synopsis. Congratulations. In terms of my comments regarding the synopsis, you didn't actually include timelines in your synopsis or your proposal or your presentation. When are you going to do what? And as I understand, normally it's a 3 to 5 years PhD program, or if it's a funded PhD, I'm sure there'll be very kind of more constrained timelines to it. So can I clarify, how much time do you have?
Thank you very much for your question. This is a funded PhD and the duration is 3 years.
3 years. And you are how much already advanced in that timeline?
Do you mind repeating that?
So how much time has already elapsed?
So we are only 6 months within the program.
So you have about 2.5 years from now, yeah? I think in my experience of supervising PhD students at University of Liverpool and in Pakistan, once you are embarking upon this journey and you are determined and motivated, so you want to do everything that you can to actually contribute to the field. And that's the notion of becoming a doctor in that area. And that's very understandable. But from a supervisor's perspective, what I would actually like to share with you is that so your first objective is about prevalence and then looking at risk and protective factors. Now, normally in a thesis, the first section is a literature review. And once you're writing your thesis and it's gone to a reviewer wants to see a very good, a robust literature review covering all aspects of that domain. And the area alone about prevalence and social determinants of mental health in South Africa, that would make a very kind of extensive literature review. And if you do it according to a good methodology, it will take you at least 3 to 6 months to write it up for a thesis. And then comes the methodology. And when you're writing methodology for a PhD thesis, your examiner or the reviewers want you to justify what are the methods out there, which method did you use, why did you choose it, what were the results, how does it compare with the existing body of literature, what are the future implications, if you were to do it again, how would you do it again, and all those things. And then comes the data and its collection and its analysis and its write-up and discussion. So if we can imagine this, just prevalence, validation, and the social ecological model and its determinants, I think that alone could merit a whole PhD. Now, if you come on to the validation part, again, this validation, if you will go into the literature review for validation, your reviewer might be interested in looking at what are the different tools, how did you identify them, why did you select these 4, what methodology did you choose for validation, how did it compare with the other methodologies, and so on and so forth. Then coming on to the intervention, and you are proposing human-centered design methodology, which begins with inspiration, ideation, and then implementation, and then evaluation. Now, each one of those steps could very well take at least like 3 to 4 months. Just working through the qualitatively with your end users through the inspiration phase, and then ideation phase, developing some prototypes around it. And once you already have an intervention that you want to implement, your reviewer might quite actually critique you that why did you actually go through that whole phase of it if from the beginning you knew what is the intervention that you're going to adapt and implement. Normally, when we are thinking of a human-centered design approach, we are going in with a very open mind. So the adolescents might say something which doesn't fit the bill of ease. So how does that fit with your plan then? So in my opinion, I think all of your research objectives are very important, and you may want to discuss it with your supervisors to actually narrow it down really. It could be just a prevalence study and the determinants of mental health for South African adolescents. It could be just the adaptation and a feasibility evaluation of the ease intervention, or it could just be the validation of outcome measures. I can well imagine any one of these areas could become a whole area for PhD. So I think I'm in agreement with your area, your topic, but my suggestion would be just to consider this and discuss this with your supervisor, because in 3 years' time, I see this is a lot. This is a lot.
Thank you very much for your comments. I'll definitely, I've taken notes, and I will discuss it with my supervisors. And I think also just outlining, maybe clearly outlining the timeline from now on, and with the ethical clearance process and each of the data collection phases.
Sure, great. Good luck.
Thank you very much, Dr. Hamdani. We really appreciate your insights. Okay, so Mirriam, I'm now going to read out Professor Matthews' comments. Professor Kathy Matthews is the Director of the Health Systems Research Unit at the South African Medical Research Council, as well as a co-director of the Adolescent Health Research Unit at UCT. So I'm going to read out, first of all, she said congratulations, that it was a well-written and well-conceived proposal, and that she enjoyed reading it. There's definitely sufficient scope. She highlighted a few strengths of your proposal, Mirriam. She said the use of a conceptual model for the risk and protective factors and the social ecological model was an appropriate choice. There was a great review of the risk and protective factors, and as well as a comprehensive review of the mental health assessment tools. And she said the selection of appropriate study designs and methods for each of the 3 phases of the research was also a strength. And then she's got a number of comments. I think I'll send you, she's got some minor points, but I'll send these on to you. Some of the major points, she said she would have found it helpful if the EASE program was described in more detail earlier on, including information such as number and length of sessions and content, and joint adolescent caregiver activities if these are part of the intervention, place of delivery, etc. And she also strongly recommended using a theory of change or a mechanism of change, showing how you think the intervention is going to work, and what the chain of results will be that would lead to intended impact. And she said this will also help you guide your measurement choices. And then one of the things she said, she asked Mirriam about group bonding. So is group bonding one of the assumptions underlying this process of change? So is it very important that the groups of adolescents and caregivers remain together throughout the program? Does it matter if the group changes over time? Do you think developing rapport within the groups over time is an important part of the change process? So Mirriam, maybe I'll pause there if you want to address the idea of the group bonding.
Thank you, Claire. I think the idea of the group bonding, I think, would be very important, considering that the EASE sessions will be conducted as, although they won't necessarily be therapeutic sessions, but they'll be conducted as group sessions, and group cohesion is particularly very important. and has shown to to impact on the delivery of the intervention. So I think it's definitely something to consider, including in the process, and building rapport with the the groups that will be undergoing the adaptation process, because I think the groups will be the same. So I think building rapport in terms of having from session 1 to session 7, I think will be effective in terms of the adaptation process.
Great, thanks, Mirriam. And then linked to that, I think Prof. Matthews suggested that you pay particular attention to retention and how you're going to retain people. Then going on to the methods, she mentioned something really interesting about the tablets, and will you be able to create an adolescent-friendly interface on the tablets to increase their motivation? And she was also concerned about literacy, particularly in some of the younger adolescents, and if you would consider an audio-assisted questionnaire whereby the adolescents would hear the questionnaire and read it at the same time. Okay, then there were, okay, apart from the queries about retention, she just mentioned that there's one issue just with the age, that it may be difficult to find 14-year-old learners. And that's, I mean, in grade 7, you have 12-year-olds who turn 13 in that year. So you may have less 13-year-olds, and also there may not be that many 14-year-olds. And yeah, have you thought about this? And yeah, have you thought about this and how the classes will be selected? So Mirriam, I think that's, as I said, she's got a number of other helpful comments, but I think we're running out of time a bit. So I think I would want to give us some time that we can have some comments from the floor as well. So thank you to both of our reviewers. I think this will definitely help us and Mirriam as we refine her protocol and her study. So now I'd like to open to the floor if anyone has any questions for Mirriam. I think just speak up because I've got 2 screens of participants here.
Hi, Claire, it's Kat. I think just from my side, and upon reflection, I really like Kathy's idea about the tablets and making it user-friendly. And I'm kind of thinking back to when Alan Flisher had done his studies. I remember seeing the early tablets and the questionnaires. They were just done so nicely to really engage the adolescents. So I'm wondering, when we have our SAG, we should really explore that in more detail, because it'll also give us a lot of lessons as we go forward working with this population. So I think it's really some really exciting opportunities.
Yeah, definitely. Thanks, Kat. I think I see one question from Simpiwe Similane.
Hi, I just wanted to say congratulations to Mirriam on an excellent presentation. I have 2 questions. One is about language, just in terms of when you do the initial questionnaires, will it be adapted to those 2 areas? Because I think it's probably Afrikaans and Xhosa mostly in those areas. And then the other one is just about if with the acceptability and feasibility, will it only be checking that in the participants, or will you also be checking that for the providers of the fees?
Thanks, Simpiwe. Go ahead, Mirriam.
Thank you, Simpiwe, for your question. And I'm not sure if I heard you correctly, but the first question was, were you asking about the language with regards to the instruments?
Yes, yes.
Okay. Yes, so we will be translating the instruments in Afrikaans and Xhosa and as well as English. But most of the schools in the area do use English as first medium. But if necessary, the instruments we will provide them in either Afrikaans or Xhosa as well. And with regards to the feasibility and acceptability, so the feasibility and accessibility outcomes, we will be examining the caregivers and the adolescents, as well as the facilitators as well. So we will be examining the facilitation skills and how they conduct the ease intervention.
Great. Yeah, thanks, Mirriam. We always find that the opinions of the facilitators on the intervention is also very important. And then I see Emily's got a question.
Thanks, Claire. Thanks, Mirriam, for a really great presentation. Quickly, I just wanted to ask, how are you going to use the findings of your validation phase in the third phase of the intervention, adaptation, and feasibility testing? You mentioned using specific cutoffs on the screening tools to identify participants for phase 3, but I don't see how the validation results actually are being used for identifying the target group for the intervention.
Sorry, Emily, do you mind repeating your question again?
How are you going to use the validation, the findings of your validation study for the different screening tools? How is that going to be used for your next phase for the actual identifying target groups for the intervention?
Thank you. So for the validation, the findings, so the pilot testing process will be for phase 1, and then for phase 2 and 3, we may use some, we'll keep some of the measures, but not all of them will be incorporated for the intervention component.
Yeah, that's right. Thanks, Mirriam. And we'll also look at the cutoff scores and how they perform. And so we'll look at the optimal cutoff score for your sample. I think maybe that's what Emily was meaning, because I mean, as you've been saying, Mirriam, your phases inform each other. So perfect.
Okay,
thanks, Mirriam. Thanks, Mirriam. Right. Well done, Mirriam.